Hello and welcome everybody to our TIF Talk tonight. We're very excited to have you here, and we have a very special guest, Dr. Alfred Johnson. You may recognize him. He has been here before. So thank you again, Dr. Johnson, for being here tonight.
Glad to be here.
Thank you. My name is Andrea Millers, and I'm with Endogastric Solutions. My background, if you watch these, might look a little different. I am traveling from out in Tampa, actually St. Pete, Florida. So a little different scenery tonight. But again, thank you for being here. This is a live event, and at any time, if you have any questions, please feel free to type them in the comment section. And we will do our best to answer all of your questions. Before we start, I do want to give you a little background on Dr. Johnson. Dr. Johnson is a board-certified physician and general surgeon who specializes in the treatment of acid reflux and gastroesophageal reflux disease, which is GERD, and related interventional anti-reflux surgery, including the TIF procedure for reflux, as well as advanced laparoscopic surgery, hiatal hernia repair, and minimally invasive digestive health surgeries. He is also not in Tampa or St. Pete, Florida. He's actually is it Merced, California, Dr. Johnson? Is that correct?
That's correct. Merced, California.
There you go. He is in Merced, California, live tonight. So thank you for joining us, and we really appreciate it. So we're here tonight, as we always are, to talk about GERD and also the TIF procedure. So Dr. Johnson, can you please give us a description of what is GERD, and what could patients potentially, what kinds of symptoms would they feel if they were suffering from GERD?
Well, GERD is also known as gastroesophageal reflux disease, and it is basically the reflux of gastric content up into your esophagus, and it can occur at various times, whether it's during a meal, after a meal, in the middle of the night, and it can result in a range of symptoms, including the typical heartburn, regurgitation of food content or acid up into the esophagus, nausea, bloating, chest pain, um, upper esophageal problems such as hoarseness, or even exacerbations of respiratory symptoms such as wheezing or uh, uh, exacerbations of asthma. So these are all in some way related to the inappropriate uh, upward reflux of content past what we will get into later is a defective valve at the lower esophageal sphincter, a lower esophageal connection between the esophagus and the stomach.
Right. Thank you very much. Now, I know there's a lot of patients that ask the question, there's the typical symptoms of, the heartburn and that feeling versus kind of atypical symptoms. And you had mentioned that the coughing, the hoarseness of throat, but there's also questions about LPR. Can you explain LPR and what the difference of that is, just to explain it a little bit?
So LPR is what we call, or is also known as laryngopharyngeal reflux. So that means that you're having reflux symptoms that are getting so high into the esophagus that they're affecting the larynx as well. Um, and sometimes these symptoms are not necessarily associated with typical heartburn. It may just be a chronic cough or throat clearing, frequent throat clearing, um, um, even frequent belching. But they may not be associated with discomfort per se, but they'll be a frequent, bothersome symptom.
Right, right. Perfect. And then let's talk about how, patients, before going into their actual surgical procedures, what do you as a physician recommend patients do to manage their GERD symptoms initially?
So initially, patients may start with simple things like antacids. So you're looking at the Tums and the Rolaids, I've even heard some patients talk about mixing baking soda and water and drinking that when they get bad reflux disease. Um, but it usually starts with these types of simple medications, which basically counteract the acid, and then you get on into medications which actually affect acid production. In this class of medications that does that will be the what we call the H2 blockers, things like Tagamet and Pepsid. One of those was already taken off the market called Zantac. But these these medications will restrict the amount of acid in the stomach by decreasing acid production. And then you get up into the highest level of acid suppression with what are known as proton pump inhibitors. And the proton pump inhibitors are very effective at reducing the production of acid, the actual acid that comes from the fundus and body of the stomach. And so when you're taking these medications, you are effectively eliminating the production of acid so that when and if you have reflux symptoms or reflux occurring, you don't get the same irritation. So it doesn't really address the underlying problem. It's just that it masks uh, the symptom because the acid is no longer there to be an irritant.
All right. Perfect. Thank you. Thank you for that. I do want to make a note. I'm seeing a lot of you guys replying or letting us know where you're tuning in from. So thank you for doing that. We will also give away a TIF tumbler tonight to those to someone. So if you are tuning in to our TIF Talk today, tonight, please do comment where you're tuning in from. I see a lot of people. We've got some California, some North Hollywood area. So we got a lot of people from different places. So thank you for tuning in. And so I'm glad you talked about, the medical therapy, Dr. Johnson. There's some patients that are out there that concerned about long-term, the long-term side effects of long-term PPI use. Can you talk a little bit about that and what is that patient who is on PPIs and wants to get off?
Well, PPIs or the proton pump inhibitors, which are the most effective acid suppression medications, are never really meant for a patient to stay on for long periods of time. So, usually these are prescribed for 2 to 3 weeks to get rid of an acute problem that causes GI symptoms. So if you're using it for years upon years, that's really considered an off-label use of a PPI. And so, there are many symptoms associated, or several symptoms associated with taking long-term proton pump inhibitors, because if you think about it, this is restricting acid. If you're restricting acid, which is normally part of your digestion, then you may be affecting something down the line. And one of those first things that could be affected is the way you absorb some nutrients, mainly calcium. And that is why we can see an association between long-term PPI use and osteoporosis, because it kind of leaches from the bones. There are several other things like dementia. There's an association with dementia, an association with kidney disease, an association with C. difficile or Clostridium difficile. So there's several other associations that have been noted from long-term PPI use, but fundamentally it occurs because there is a change in the environment created by the lack of acid in your stomach.
All right. Thank you. So we've got quite a few questions popping up. So if you don't mind, I'm going to ask a couple of the questions that have come up. We've got Pamela who's asking if gastroparesis can cause GERD, which can cause chronic sinusitis, which should be treated first. And then she goes on to say, how long can a person be on PPIs and sinus medication? It's been a true roller coaster. I'm sorry, Pamela.
Well, that's an excellent question because the symptoms of gastroparesis and reflux together are many times hard to um, decipher. And if you are having significant nausea with your reflux, one of the things that is done typically is to get a gastric emptying study to evaluate the function of the stomach to see whether or not the lack of propulsion in the stomach is leading to the nausea. Um, and, because some patients just with severe reflux may have significant nausea, but no gastroparesis. Um, so if it is truly determined that you have gastroparesis and reflux, there are some other procedures that we will sometimes consider doing while treating the reflux. One of those would be by opening the outward flow from the stomach. A procedure called a pyloroplasty is something that could be done at the same time as a definitive procedure for reflux if it's determined that gastroparesis is part of the symptom.
Okay, perfect. Thank you very much. Let's talk a little bit about the different treatment options for GERD. Obviously we're going to talk about the TIF procedure, but there's the Nissen fundoplication and other procedures as well. Can you discuss those if you don't mind?
So the first procedure that was probably done to treat reflux was actually just simply a hiatal hernia repair. Many years ago, probably like in the 50s or so. And then what came from that, the next procedure that was done frequently would have been the Nissen fundoplication, which is a circumferential wrap of the stomach around the distal esophagus or lower esophagus. And there have been several iterations of the Nissen fundoplication, but for the most part, they are circumferential wraps, meaning all the way around. And then you get into what are called partial fundoplications. So those will be what we call the toupees or door fundoplications, okay, which do not encroach upon the distal esophagus all the way around. The problem with the Nissen fundoplication has to do with the fact that it's all the way around or circumferential. And with these patients, they have some kind of undesired symptoms which can occur because of that. One being gas bloat, because basically you go from a lower esophagus, which was very compliant in allowing a lot of things in, to all of a sudden being very a very stern barrier to reflux. And so things go the other way. So that's kind of what leads to the gas bloat, but it also leads to some difficulty with swallowing. So dysphagia is something we will see frequently after Nissen. So the other thing that sometimes surprises people about having a fundoplication is that they cannot vomit after the surgery. And if you end up with a bug, a gastric or gastroviral illness, and you need to vomit, and you happen to be in the hospital, you need to let the physician staff know there that you have had a Nissen fundoplication previously, because they will put a tube into your stomach to evacuate it and decompress the stomach so that you can relieve the symptom. But those are just several things that are considerations for Nissen. Now, the Nissen does work at reducing reflux. There's no question that it reduces reflux. The problem with it is that it causes other adverse side effects.
Right. And you mentioned the hiatal hernia portion of it, and I know we get a lot of questions from patients as to, can I just get my hiatal hernia fixed, or do I also need to get a TIF or a Nissen as well? Can you talk a little bit about kind of that combined, what we're calling CTIF or combined hiatal hernia TIF procedure?
So I think the way I would describe it is if you look at a normal configuration of the esophagus and the stomach kind of comes into the esophagus comes into the stomach at an angle, and it's usually that angle that the esophagus is coming in, that what we call the angle of His, that helps to establish a reflux valve. But actually, very in close proximity to where the angle comes in, the diaphragm inserts, kind of impinges upon the esophagus too. So it's a complex area where you have diaphragm coming in, you've got the angle of the esophagus joining the stomach, and you have what's called a phrenoesophageal membrane. And all of these things together provide a competent valve or barrier for reflux. And if something is not, um, something is amiss among all of those components, then you may have the creation of pathologic reflux. Now, when you start to get a hiatal hernia, then the what you're seeing is a laxity of all of those components, and there's a sliding of the stomach slowly into the chest. Um, so that the junction between the esophagus, which would normally be below the diaphragm, is now in the chest. It may be, 2 centimeters, 3 centimeters. It doesn't have to be far, but that that displacement of what we call the gastroesophageal junction, um, is primarily what leads to these symptoms.
Right. Perfect. Thank you. Before we go into the explanation of what the TIF procedure is, I'm going to go through a couple of questions. We're getting a lot of questions, Dr. Johnson, which is good.
Okay.
So, so let me get through here. We asked Pamela's question. So let's get to Joyce. She's asking, does GERD mimic chest pains akin to heart problems?
That's a very common way that it gets detected in the emergency department. So sometimes people will wake up in the middle of the night with some severe chest pain. They'll go to the emergency room and get their EKG, they'll get lab work done, everything comes back normal. And then what the ER physician may do is give them a GI cocktail. Now, the GI cocktail has things to treat GERD. So it may have something to help relax the esophageal muscle. It has some medication to counteract the acid, and that usually does the trick. It relieves the chest pain in that scenario, but the cardiac issue has been ruled out. And so, apart from whether it's cardiac, whether it's actual reflux, you could also have the same kind of mimic of symptoms from a severe episode of gallbladder disease.
Mm.
So those are usually the three things that have to be ruled out. Somebody comes in with chest pain, you're thinking either underlying heart condition, acid reflux, or gallbladder disease.
Thank you. So Mindy's asking, I have saying she's got two GI doctors. One says that she has Barrett's esophagus. The other insists she doesn't. Uh-oh. I was put on omeprazole or pantoprazole. I can't say it right. Pantoprazole.
Pantoprazole, yeah.
Yeah,
Or
thank you. For GERD for years. And she said she was diagnosed with BE 4 years ago. Is TIF an option for me?
Yeah, TIF is still an option. Really, most forms of anti-reflux surgery are still an option, as long as there's no significant dysplasia with the Barrett's esophagus. So Barrett's esophagus is a product of long-term GERD, and what happens is that the esophagus is basically adapting to the frequency of seeing acid. The esophagus is not used to seeing acid. The stomach is used to seeing acid. So when we see Barrett's esophagus developing, what we're seeing is a transformation of the lining of the esophagus to accommodate the acid. Okay. And when it accommodates the acid, then there are abnormalities found when we take biopsies. And so this is something that goes in stages. It starts out as intestinal metaplasia, and you get to mild dysplasia, moderate, severe dysplasia, and then you end up with carcinoma in situ. This is all a progression. And so what it leads to ultimately, in a very small percentage, but still significantly higher than the general population, but it leads to adenocarcinoma of the esophagus, which is the fastest occurring, not occurring, but the the incidence of this has grown faster than any other cancer in the last 50 years.
Yeah. That's interesting that you bring that up. Next month is April. In April, it's Esophageal Cancer Awareness Month. So I'm glad you had mentioned that and kind of what the progression looks like up until potentially could be esophageal cancer. So thank you for that. Joyce is asking, she says she doesn't experience, where did it go? Any acid reflux, nausea, or food coming up in her throat, but heartburn. So I guess that's just a comment, if you will. There is a question here that I did see, and it was how long did it last? So before we do that or answer that question, maybe let's explain what the TIF procedure is, and then you can discuss how long it lasts, if you will.
Okay. Well, the TIF procedure is an endoscopic fundoplication. And the way I like to describe it to patients is if you think of losing the laxity of the lower esophageal, the lower esophagus where it can to the stomach, and it's lose that laxity, you kind of lose the angle. You lose the angle of His, and when you lose the angle of His, your esophagus and your stomach are kind of migrating into the chest, and it looks more like a funnel. And so what we try to do with the TIF is to recreate the angle. So we're kind of pulling the edges down using this device to reestablish the angle and reestablish a normal functioning valve between the esophagus and the stomach.
Perfect. Thank you. And then if you don't mind answering, how long does the TIF normally last in patients?
So the TIF procedure has been performed since about 2007. So it's a relatively new procedure for reflux, but it's approaching somewhere around 30,000 patients around the world who have had it. And these patients are, I'd say at least 80% of them have been able to get off of their proton pump inhibitors with relief of symptoms. And the advantage of the TIF is that we don't see, again, because it's not a circumferential treatment of the disease, it doesn't go all the way around the esophagus, and so we don't see this constriction that we see with the Nissen fundoplication. So the swallowing is easier. There's no inability to vomit if you need to vomit. There's less gas bloat, and there's less of the frequent belching that some people have associated with this.
Right. Thank you. We got a comment from Debbie. She's saying, "Hi, Dr. Johnson. I live near Merced, California. I will be setting up an appointment with you soon." So there you go.
All right.
Fantastic, Debbie. Okay, so we've got a question from another Andrea. Is there benefits or are there benefits to getting a C-TIF versus a partial fundoplication if you require a hiatal hernia repair? That's a good question.
So one of the limitations of the TIF alone is that if you do have a significant hiatal hernia, usually more than about 2 centimeters, we can't really pull all of that down in a sense to we can pull it down. It's just that what will happen is that now you would have a competent valve, but you would still have the hernia. And so it's, even though it would work better than nothing, it just would not work as well as the C-TIF, meaning the hiatal hernia repair with the uh, with the TIF procedure being done at the same time.
All right, perfect. Another question we're having is from Chad. Do I have to be on medication for a certain amount of time before I'm allowed to have this procedure?
Well, I would say that most of the patients that I see have been on medication for some time, and it may have only been a year, 5 years. I've had patients that have been on proton pump inhibitors for 20 years, who were unable to get off because once they stop the mission, they basically get rip-roaring symptoms um, and put themselves back on it.
Right. Right. Okay.
So,
Well,
so
I guess
there's no minimum, there's really no strict minimum, but we do have to, one requirement for anybody having anti-reflux surgery is that you do have to prove reflux.
Mhm.
So, the question would be that, if you've only been on it for a short time, are we really sure you have reflux?
Right. So that's a really good question is what is the diagnostic testing that you do to determine what if patients are a candidate for the TIF procedure?
So the diagnostic testing is basically three-pronged. One, starting out with a simple test like a barium esophagram, in which you swallow contrast. X-rays are taken while the contrast is swallowed, and that will a lot of times give us very important information about the esophagus in terms of the muscular function of the esophagus, whether or not there is an associated hiatal hernia, and whether or not there is free reflux seen on the study itself. Because if that's seen on the study, there's no question you have reflux. Another part of the workup would be an endoscopy, or flexible endoscopy, which is done with a flexible scope with a light on the end of it. And this is put down in order to not only take biopsies of the distal esophagus, we can better quantify the size of the hiatal hernia, and we could also evaluate the stomach for any other pathology. And then another part of the workup would be the 24-hour pH and manometry testing that can be done. That's important for patients who don't have hiatal hernias because if you these patients can actually have a TIF procedure alone. If you can prove that someone has reflux and they have no hiatal hernia, then they can have a TIF procedure alone with no incisions. So that's a very important component to the
Determine.
diagnostic workup of reflux.
Yeah.
The manometry testing allows us to know, that in an esophagus basically pushes things through in an orderly fashion in terms of the muscular function of the esophagus. Because there are other conditions that sometimes mimic reflux, such as esophageal spasm or achalasia, that the manometry will pick up. And these patients would not be a candidate for a TIF or any type of fundoplication.
That's a good point. Yeah, thank you for bringing that up. So I have another question from Phil. He's saying he's had a Nissen in the past, but still having severe reflux again. Is it possible to do the TIF procedure even after he's had the Nissen procedure?
It's possible, but it requires further workup because sometimes we end up having to take a Nissen down and reconstructing it. And what I've done in my practice is in the patients who've had that problem, we take the Nissen down and we redo it with a TIF. And almost all of these patients have an associated hiatal hernia when the Nissen breaks down.
Right. Susie's asking, can you have the TIF if you have no gallbladder?
Yeah, there's no reason you can't have a TIF if your gallbladder has been removed previously.
Perfect. Thank you. Okay, another question. Dr. Johnson, have you noted a preponderance, sorry, it's small here, of patients with gastric Bezoar, or poor gastric emptying after lap Nissen fundoplication with full wrap when extensive metatarsusal dissection of medium to large hiatal hernias is required? That's a pretty technical question.
Um, yeah. Can you read part of that again? And I can maybe
Yes.
do.
Yes. It's from Keith Donald. He's saying, Dr. Johnson, have you noted a preponderance of patients with gastric bezoar or poor gastric emptying after lap Nissen fundoplication with full wrap when extensive metatarsusal dissection of medium to large hiatal hernias is required? This is more of a technical question.
Okay, so what we're kind of talking about there is some of the GI upset after a Nissen, and it sounds like the original Nissen was complicated by the fact that there was a large hiatal hernia or maybe a paraesophageal hernia with it. And sometimes in those cases, there can be some impingement on the vagus nerve. And so if there's been any kind of a vagus nerve injury during that original dissection, then you could get a postoperative gastroparesis, and you could have poor outflow from the stomach due to the previous surgery. But that's something that usually is fairly, easy to detect on a gastric emptying study. So if the gastric emptying study is abnormal, then that's, that may be part of what's going on.
Thank you. He is a physician, Dr. Johnson. I just saw further down that he posted. He is a general surgeon that just asked that question.
Sure.
He has a robust anti-reflux component to his practice and has done quite a few TIFs, about 50. He says he does his diagnostics and surveillance endoscopies and hybrid. All of his procedures are hybrid. So
Yes.
that makes sense why he was asking that question. Thank you, Dr. Donald. We have another question from Mindy. She was asking, what was the name of that last diagnostic test? And I think it was the manometry that you were talking about.
So it's 24-hour pH monitoring, usually done with a Bravo probe. And then there's what we call an impedance esophageal manometry. And that manometry is just what we use to evaluate the muscular function of the esophagus to make sure that there's no other condition that would prohibit you from having a fundoplication of any kind done.
Yeah. Okay. So, we didn't discuss yet kind of what can patients expect kind of post surgery, and then what is the diet and exercise? What's it look like for a patient to resume physical activity after? So more recovery from the TIF procedure. Can you discuss a little bit of that, if you don't mind?
Okay, so I'd say in my practice, the majority of the patients that I'm seeing are people that are kind of late in the spectrum of gastroesophageal reflux disease. So almost all of them have large hiatal hernias. So we've been doing the CTIFs, or the combined procedure of the laparoscopic hiatal hernia repair with the TIF. These patients are actually going home on the same day. So when we do these patients, we're doing them outpatient. They go home the same day. They're on a modified diet for several weeks. And the modified diet is just, we give some guideline with regard to what they should eat so they don't have to think about it. But if they take their time, drink plenty of liquids, chew their food very carefully, and don't, go out and eat a T-bone steak on the night they had surgery, then usually don't have a part. You just have to remember that you have to chew carefully. You cannot eat as fast as you used to eat, at least while recovering from the surgery. In terms of physical activity, we usually allow patients to go back to work within 2 weeks, in terms of normal employment.
Great. And what about we get a lot of questions. I know this seems odd, but people are asking, can I lift weights again? Can I do yoga? Can I ride bikes? It, what are your thoughts on that when
So
exercise?
a hernia, if we're fixing a hernia, especially if we're fixing a hiatal hernia, you still have to remember that it's a hernia. So any hernia responds to increases in intra-abdominal pressure. So if you're going to do anything that increases the pressure, that you will put some structures at risk. Um, so, you want to let things heal before you really, uh, especially if you're going to be doing abdominal crunches in the gym, this kind of thing. Usually you need a little bit more time um, before going back to that type of activity compared to going back to a desk job.
Sure.
Um,
Sure. That makes. We've got a question from Liz. She's saying, does one have to have the manometry? What if one can't get through it? What happens if someone fails the test? Is it like a requirement? I guess she's asking.
so it's not really a question of failure. It's really a question of, have we completely evaluated your esophagus? Do we know for sure that you have reflux? And do we know for sure you don't have something like achalasia?
Mhm.
Um, because the only reason that there used to be a difference in fundoplications was because if you had a weakened esophagus from years of reflux and the muscular function wasn't great, we might offer you a partial fundoplication rather than a Nissen fundoplication.
Mhm.
So my reasoning is that if I'm not doing any type of fundoplication that would restrict the way you swallow or prevent you from swallowing. The only thing is that if I don't know for a fact that um, if I haven't ruled out the fact that you have something, an underlying muscular function problem like achalasia, that's where we could run into trouble. So as long as we are sure that um, that's the problem, um, then the TIF procedure has not been an issue. In fact, the majority of my patients have not gotten manometry studies.
Mm.
Um, so, manometry is something that is I would say reserved when the diagnosis is in question.
Okay.
When you have a patient where the diagnosis is in question, um, they need not only the 24-hour pH to really make sure that that's what they have, they need to have manometry to make sure that there's no other muscular dysfunction of the esophagus.
Thank you. One last question before we kind of conclude, and then I also want you to tell everybody where you're located, so if they want to get a hold of you. But there is a question, and I think this is interesting. And you talked a little bit about this. It's in Drag, and she's asking, is there less side effects having a CTIF versus having a traditional toupee wrap? She's basically trying to determine advantages of TIF over partial wrap, since I would need a hiatal hernia repair. So she needs a hiatal hernia repair, and she's trying to decide between also having the TIF or a toupee.
So I could answer that this way. I was someone that did Nissen fund applications for many, many years. Um, and then I got involved doing the TIF procedure. Now, for various reasons, I'd started the TIF program at a hospital, which early in the years, insurance funding was a problem with the device, and we didn't get the device in anymore. So in those patients, after seeing that the TIF was working, I completely switched my practice to do partial fundoplications. So I have not done a Nissen fundoplication in more than 10 years.
Wow.
But I would tell you that the difference between a partial fundoplication, which will be a toupee, and a TIF procedure is that we still have to use about 10 to 15% of the stomach to do a uh, toupee fundoplication. So you still have a portion of the stomach being wrapped when you do a toupee. Now, you don't have the same side effects that you do with a Nissen, but you have a significant portion of the stomach wrapped. So one of the things that the TIF procedure allows us to do is to continue the proper. There's something that Dr. Chang describes as accommodation. Um, you're able to the stomach is able to accommodate changes in capacity. But when you take some of that away by using the fundus to do a wrap, even if it's a partial wrap, you've taken some of that away. Um, so for me, that's as good a reason as any to do a TIF procedure versus a toupee procedure.
Perfect. Thank
I don't know
you.
if that answers the question.
No, it was perfect, actually. It was great. Thank you. And, can you please let everybody know who's watching where you're located and how they can actually get a hold of you if they'd like to schedule an appointment with you? I know we have it up on the screen, but maybe you can kind of explain where you are and.
Yeah, I'm located in Merced, California, in between Fresno and Modesto. And currently, I'm the only provider of TIF in the San Joaquin Valley.
Okay.
So I'm the only guy doing it, but we are located in Merced, which is about an hour and a half from Yosemite. So,
yep. And your number is on the screen too. So if anybody is interested in contacting Dr. Johnson's office, you can call that number to schedule an initial consult with Dr. Johnson. If you are watching and you're not in the California area or near Merced, you can go on GERDhelp.com. We do have a physician finder on there, and you can just zip code or your state, and you'll be able to look for a TIF trained physician in your area. Before we conclude, Dr. Johnson, I just always like to ask, is there any final words of advice that you would give any patient that is considering, either the TIF or any other treatment option for GERD at this time?
Well, we've been very pleased at the results we've had with the TIF procedure, and for patients that have significant regurgitation. It's like night and day overnight, the difference they feel in terms of things not coming up, and the relief of heartburn. So I would really implore you to think about what your options are, and to make sure that all the potential options for the treatment of reflux are being offered to you.
Perfect. I don't know if you guys are watching, but Dr. Johnson, our last TIF Talk that we had with him, you actually had a patient on with us, right?
Yes.
If I remember correctly, and they were able to tell their story. So if you go to our YouTube channel, you can find the previous TIF Talk with Dr. Johnson, and you can watch and listen to his patient talk about his was it who was it that you had on? Was it female or male? I can't remember.
Female, yeah.
That's right. You can listen to her story and her experience with having the procedure. So again, Dr. can't thank you enough for joining us this evening. We really appreciate it. And if you're watching, please feel free to reach out to Dr. Johnson or get on GERD Help and be an advocate for yourself. Again, next month is Esophageal Cancer Awareness Month. As Dr. Johnson had mentioned, is one of the fastest growing cancers, unfortunately. So we will be doing a lot to raise awareness around that in the month or up until April. So thank you again, Dr. Johnson, for joining us. Everybody that's on, thank you for joining us. If we didn't answer your question, I saw a ton of questions come through. We'll try to reach out to you either direct message or even maybe Dr. Johnson might be able to reach out to you as well. So have a good night, everybody. And next week, we're always on Tuesdays. So catch us next time on our next TIF Talk. So have a great evening. Thank you very much.
All right.
Thank you.